Thank you, dear chairpersons, and thank you each one for making this Aakriti a grand success. With this, I also would like to thank Dr. Ragini, whose brainchild it was to create, to bring people from all over Delhi with different specialties and making a team where each one is unique in their own way. And we are 18 friends who are involved in this. So since Dr. Rita has already set up the stage for me, I don't think we need to go much into theory. And after ovarian rejuvenation, we can sort of talk a little bit on the endometrial regeneration. So we all understand that we need a competent embryo and a receptive endometrium for a good implantation. And any thickness less than 7 is a refractory endometrium and compromises the success. But we have various scientists giving different cutoffs, minimum ET ranging from 4 to 7 and optimum ETs ranging from 9 to 14. So we know if it is a thin endometrium, there is high impedance to blood flow, there is impaired glandular epithelium, there is decreased VEGF expression and a poor vascular development. And the evidence also states so, and we see that whenever the endometrium is less than 7, the chances of a success is less. So we have this strategies to manage refractory endometrium, and it was shown that red, whatever is marked in red has no benefit, yellow is unclear, and green is beneficial. So only thing beneficial is a hysteroscopy for to see the endometrium or to help it recover, maybe by some causing injury to the endometrium. And what is the role of intrauterine GCSF? It is red. So intrauterine GCSF doesn't help. Maybe subacute GCSF is something which should be given. Now, intrauterine PRP, unclear effect, and the stem cells also is unclear effect. With that thing in mind, we know the stem cells, we have been talking since morning, and all over the world, so many countries are working on it. And we all understand that everything is revolving around these growth factors, around the cytokines, the anti-inflammatory properties, and promoting the regeneration whenever we talk of anything on PRP or on stem cell. So we have this latest paper in January 22, which suggested the cell-based therapy in thin endometrium and Asherman's. And it has shown that you use anything. You use PRP, amniotic embryo cells, stem cell scaffold structure. What all they do is they increase the growth factors and thereby improve the endometrium, causing giving a successful implantation. So PRP, the most commonly thing that we can all do because it is autologous and it is very simple to prepare. We are not talking of hi-fi things, though we have experts who have already shown us since morning how bone marrow stem cells can be used, but PRP is something very simple. Any gynecologist, obstetrician, or an infertility specialist can prepare it, and we know it by different names. It can be called platelet gel, PRGF, plasma-rich in growth factors, or a platelet concentrate, and it is nothing that we do. We draw the blood from a peripheral vein, activate the platelets, which release cytokines, growth factors, including various growth factors like VEGF, transforming growth factor, platelet-derived growth factor, epidermal growth factor, and all they increase these progesterone receptor activities. It is autologous, and therefore it is very, very safe. And not only in gynec, we have seen it being used in various other specialties, be it orthopedics, traumatology, dentistry, dermatology, cosmetology. So what is these, what are we doing in PRP? These platelets, which are derived from megakaryocytes in the bone marrow, they contain these two sort of granules, the dense granules and the alpha granules. And these platelet-derived factors help in angiogenesis, epithelialization, proliferation, and differentiation. And we have these numerous growth factors that are released from these alpha granules, which are helping in regeneration. So we have various methods. We have various times whether it needs to be prepared, the duration and the RPM that it needs to be prepared in. And we have multiple speakers have shown us different timings. So it can be anything. What I follow is that we take, if we need to make we can take 10 ml blood or a 50 ml blood, depending on that. If we take 1.5 ml of anticoagulant, that is ACDA, and we take 8.5 ml of blood. So it has to be, ratio has to be something of 9:1 roughly. Or if you need to make more, then you take 45 ml blood and 5 ml of the anticoagulant. Mix it well, centrifuge it for 15 minutes at 1500 RPM, and then we see the blood being divided into those 3 layers, the red cells in between the buffy coat, and then we have the plasma on the top. Now, again you remove that plasma and take it into another tube, centrifuge again, get a pallet, and then again you take that pellet with 5 ml of supernatant and you take it for your infusion into the endometrial or the endometrial perfusion. So it makes those platelets 7 to 10 times more concentrate. So this is something what Dr. Rita has already shown you. So this is how we have these kits that provide that PRP, which is ADCA. So you take some bit of maybe 1.5 ml into a conical tube, take blood, and then you mix this blood well and put it into the centrifuge. So now we are mixing this ADCA with the blood very well and placing it. So we need to be very careful that we have to balance the tube always in a centrifuge. That is the basic funda whenever we are centrifuging. So we have to balance the whatever ml of blood is there, we centrifuge that amount. We take a balancing tube with a normal saline or water or whatever, and then we set the centrifuge for 13 minutes at 3000 rotations per minute. And accordingly we get this supernatant, which contains the plasma. So in the second, that is the first cycle, and in the second cycle again you take that supernatant and take the pellet of the platelet with 1 ml or 1.5 ml of the plasma. So this is a very simple, like we do IUI, we just clean the vagina copiously with a normal saline and infuse very slowly without damaging the endometrium, and this can be done in the previous cycle. It is not done in the same cycle. So this is how we get this pellet here at the bottom. This is the plasma poor plasma. This is the platelet poor plasma, and this is the platelet rich plasma. So you can take some pellet along with 1.5 to 2 ml of this platelet rich plasma. So this, it has multiple these interleukins and the growth factors which are affecting the endometrium. So actually it was started in 2015 by this Chang et al. And they got miraculous results. They put it in 5 patients where the endometrium was thick, it was not improving with the estradiol valrate and even with Optithic. And they've tried it, and in all the patients they got pregnancy. So whether it was a miracle or whether it was what it was, but it started with those encouraging results. And then the things started up, and it picked up, and then it was suggested that the plasma, which is rich in growth factors, it improves the biological activity of the endometrial fibroblasts and helps in regeneration. So various papers and the various therapies and how they help is by upregulating the interleukins, by increasing the MMPs, or by downregulating pro-inflammatory genes, or by encouraging the endometrial growth. And so the multiple workers have been working on it. So that was about PRP, bone marrow derived stem cells. We have seen Dr. Rajput, how nicely he has explained to us how we remove those, how we take the bone marrow blood. And the bone marrow concentrate contains so many these progenitor cells, the hematopoietic stem cells, and the mesenchymal stem cells, and they work by doing angiogenesis, by neovascularization, and all. So basically it is the increasing growth factors which is increasing the endometrium and helping us out. So this was also a very recent paper in 22, where they have used bone marrow mesenchymal stem cells in a rat model, and they have, this is basically because of the immunomodulation that it works, the stem cells. Not only that, amniotic epithelial cells can be taken from the amniotic membrane or from the umbilical cord, and this is can be harvested abundantly, and it is non-invasive. So this is since Dr. Rajput has already shown us very in detail, I think we will skip it. And coming on to another thing which can regenerate the endometrium is the growth factors. So we have the granulocyte colony stimulating factors, or the GCSF. We all I think as infertility specialists, most of us you have been using GCSF very often. Now, this is something, it could be used, endometrial perfusion could be done, but since the evidence says it does not work, GCSF, as Dr. Rita was saying, we can give subcutaneously much before whenever we want to do the bone marrow aspirate for the stem cells. So it does help a lot before doing the bone marrow stem cell aspiration. And since it has a half-life of 3.5 hours, it can be given by subcut or even IV injection diluted, and or as a perfusion. And normally we can give it, if we see the endometrium is not that good, it can be given in that particular cycle before giving HCG, or even on the day of pickup. So basically it is the anti-apoptotic activities, the pro-angiogenic activities, the antioxidant activity, the immunosuppressive activity, and the immunomodulation. These are the 5 things that are being changed by these stem cells or by the PRP. And it is, what about the safety? Since it is prepared from autologous blood, theoretically there are minimal risks of transmission or reactions or cancers. And the sources are abundant. It could be umbilical cord, the amniotic membrane, bone marrow, adipose tissue, menstrual blood, or even autologous endometrial biopsies. So whether to use a PRP versus a bone marrow aspirate, or they can be used in synergism, is still being, I think, researched, and we all are working on it, and gradually things will become clearer with time. So PRP is improving the platelet concentration, whereas bone marrow cells can be used when the things are more severe damage to the tissue has occurred. Now, what is the problem? Is because we don't know what is the ideal concentration, which technique is better. We have various commercial products. Each has a different efficacy and a biology. And we need to also see the hysteroscopy. We have to rule out other pathologies before we use either PRP or the bone marrow. We should also rule out infections, and definitely if only we do it when the endometrium is less than 6 mm. So this is how we inject the PRP into the endometrium. This is the operative hysteroscope, and this is the side channel, and from that, this side channel, so from the side channel, once we have prepared the bone marrow stem cells or PRP, whatever you are using, so through the operating channel, the side channel, you can put this ovum pickup needle, and it can be put at various places. So it can be, this was a very bad cavity, and the endometrium was very thin, so it was 1 ml each can be injected on the various, on maybe posterior, anterior, and the lateral sides. And then maybe after 2 to 3 cycles, once these cells start generating, one can do the endometrial transfer. So, once we are using that, we can use a 3-way, so that when we are removing that needle and putting it at the other side, that the plasma does not gush out, and one can use a 3-way, close it, take our hysteroscope to the other wall and inject there. So it has a role in endometrium, in RIF patients, in premature failures, even in male factors. And various studies have been going on, and I think this was an Indian study by Dr. Nagori, where they have used the bone marrow derived cells, and they have put it in the cavity under ultrasound guidance following curettage. So actually people have used multiple things. So whether it was the curettage that affected, or whether it was these cells, the bone marrow, that has done the role. And then, so still things are becoming clearer with time. So we have these on these regenerate, the critically, so now this practice guidelines, the Canadian guidelines, what do they say? That with thin endometrium patients undergoing embryo transfer, guidelines are suggesting against the use of these cells to improve the pregnancy rates, because there are only case series and case reports, and further research needs to be done. Also, there is a growing list, but US FDA also does not approve it. And to conclude, though it is something very good for a complex situation, but a hysteroscopic evaluation is must. And if treatment to increase the endometrial growth fails, additional methods like the bone marrow stem cells can be offered to the patient, but you have to take an informed consent, do a proper counseling, explain to the patient that it is still under research. It may benefit, and the risks and benefits needs to be discussed with the patient. It has a futuristic approach. It is it is a simple, easy to use process, autologous, cost effective, but despite the promising results, we have to have more studies, and we have to have more data. So still, out of the mountain of despair, a stone of hope can be given to the patient, and if we sincerely talk to the patient, I think this is something which which can help our patients in despair. Thank you so much.